welcome to On Call with the Prairie Doc After Hours. We had great questions submitted beyond what we could answer during the show, and so let's get started and do those right now, correct? Antidote for heroin is what? And tell us about it.
It's called naltrexone, so it blocks the mu pain
Or
receptors.
Narcan is the brand name.
Narcan's the brand name. Comes in a nasal spray, comes in an injectable. And so if a person is found unresponsive and we think it's from a heroin overdose or from an opioid overdose from pain pills, you can administer that, and within minutes, the patient will wake up.
If it's narcotic.
Yep, it's an antidote, means it is the opposite effect. Yep.
In fact, we're taught to give Narcan in the field on an unconscious patient from whatever reason.
Yep. It can be given in a once-a-month injectable also, so people in recovery sometimes will go in and get that injection.
So that it lasts, and then they don't get the same effect from their narcotic.
Yeah.
It's very expensive, and it's generic, and it's been around a long time, and they got us over a barrel. Doesn't that make you mad?
Yeah. But check, insurance can cover it. And if you get it in the inhaled form, it may be reasonable. Check it out. Check the pharmacist.
Contract for pain. Let's talk. You just touched on it a little bit. Is that an effective way of controlling overuse of narcotics?
Yes. I think the effectiveness of it is, I want to trust you. You want to trust me. I want to make sure that you are an informed patient. There is risk with this medication. And so let's take it seriously. Let's be professional about it, both as a clinician and as a patient. And let's work together on this.
And every year
every year it should be addressed. And if I have a patient that's on a controlled substance, that means it's a prescription that I have to write out a prescription, and it has to be looked at by the pharmacist in that way. Every 3 months, I want to have contact with that patient. Now, I might not see him once a year, but I want contact.
DMP. Let's talk about way to monitor people's use. You know, I'm an ER doctor. A person comes in, they want narcotic. I go right to this. What is it?
So the Prescription Drug Monitoring Program is a national movement that's a computer base of all the controlled substances that are prescribed to patients. So if a patient says, I only get this pain medicine once in a while from my one doctor at this one clinic, that doctor can go into the Prescription Drug Monitoring Program within about 3 minutes, look to see what's been filled. And if it says, no, this person's been filling this by 6 different doctors at 8 different pharmacies, that emergency room doctor is going to say, you know what, you've not been truthful with me, you're seeking drugs, I want to help you, but the help is not giving you the pill. The help is getting you treatment for your addiction.
So what is diversion?
Diversion is taking a controlled substance that's been prescribed for you and giving it to somebody else. All right. It's a felony. It's illegal.
And what about fentanyl? Right now there's all these people are dying of fentanyl overdose. I've heard that they're on heroin, and then it gets mixed with fentanyl, and then they overdose.
So fentanyl is a medication that's been found in these patches. They're pain patches. We use it not uncommonly.
It's a great drug. I use it for my terminal patients. I use it all the time as hospice director.
Yep. It's a very helpful.
Long-acting, smooth, easy.
But when it's used in the wrong hands, for a person that's using it inappropriately, it's very dangerous. And people that are addicted will take it and they'll figure out how to inject it. There's different ways they'll try to do it. They'll try to get it underneath their tongue, that type of thing. And so what we see is the heroin, which is a short-acting opioid, is mixed with fentanyl, which is a long-acting opioid, and is about 100 times stronger than the heroin is.
And then they overdose.
And they're not tolerant to it. Now, what's really scary is there is actually literally an elephant tranquilizer that is made out of a super fentanyl, which is 100 times stronger than fentanyl. So back in West Virginia, where this is a huge problem, in one afternoon, in 4 hours, 23 people died of opioid overdose.
Because they got some elephant.
They got heroin with the elephant tranquilizer.
Oh, jeez.
Yeah, sad.
So someone called and asked about their wife who has lung disease and sleep apnea and narcotics. Is she at higher risk for?
Higher risk. So I would go and talk to the physician and say, we understand that there's risk involved between taking chronic opioids and people that have underlying lung disease for respiratory depression causing unintended overdose death. I'd have it reevaluated by her physician.
Right. In the emergency room, there was one patient that came in, heavy person, sleep apnea, overdose.
And if they are
Dead.
drinking alcohol, that would really, really be dangerous. Yeah.
What do you think about cancer patients taking drugs such as oxycodone for a long period of time as part of their treatment?
So what we do is we call this chronic pain non-cancer chronic pain. So it's NCCP. People that have cancer pain, we want to talk, as a team of the physician, the oncologist, the family physician, the nursing staff, palliative care team, if that is such. Are they in hospice? All these questions. We want, if a person is not in hospice and they think their life expectancy is long, we would ask the patient, there may be dependence that you get from this. You let us know, we want to work with you. But with the person with a terminal illness, we tend to go on the side of the patient's request.
Yeah. Well, as the medical director for our hospice for 20 years, 5 years in this community, rarely do I sense that there's an abuser.
Yeah.
We've had one a year ago.
Yeah. Okay.
And we knew it, and we are doing our best to just make a contract and all that stuff. But but when someone's suffering and they're terminal, turn up the pain.
Again, it's not a it's not a light switch. It's not black and white. It's a gray zone. These are appropriate medicines. These are very helpful medicines when used appropriately.
Right. It's a difficult issue though, because not all cancer pain can be relieved. And what happens is, as my father had, we gave him enough pain medicine. I wasn't prescribing, I was watching this. His doctor prescribed the pain medicine and he would become out of it. He would be completely unconscious, so that you wake him up to let him come back to a wakefulness, and then the pain was so bad he couldn't tolerate it, and of course there's that phase of confusion in between.
And those teams of nurses, physicians that are hospice teams, they do an incredible job. My hat's off to them.
Oh, I love my hospice team.
Absolutely. They're fabulous.
And some of them might be watching. I love you. In regards to treating neuropathy, what drugs are safe and unsafe, or helpful or unhelpful?
There are drugs, they're
Gabapentin.
Lyrica, gabapentin. They have some effectiveness. I find that neuropathy is a very, very difficult pain to treat. Opioids tends to not work for that. Unfortunately,
it's not a mu.
No, and so again, I would try to work with your physician on that. What's your function? How are you able to get around? What's your quality of life? And again, there's not a right answer for this. It's everybody has one. It's just very difficult. It's a difficult pain to control.
I've used amitriptyline and nortriptyline for this group. I have used the SSRI medicines like Prozac or fluoxetine or those kinds of medicines.
I love those sheep wool boots that people have that keeps the pressure off of the bedding, things like that, the bed surface. So just those little things like that for some of my patients makes a big difference.
Chemotherapy will give peripheral neuropathy. I'm an experienced man on that whole thing. I can tell you it is something you just live with. I don't think there's a thing you can do really. The pill, take a pill. I don't want to take a pill. I am on oxycodone. I've been taking it for 5 years. I'm fairly congested. I have to blow my nose at least 5 times when I get up in the morning. Is this a side effect? Also, first thing I have to do in the morning is to take my pill. Is there a chance that I might be addicted to these drugs?
Okay. Yes, it is a side effect. The congestion.
Congestion is very, and constipation as well.
And constipation is a common one, And so addicted, we don't know, unless you're out trying to get the drug and seeking it and doing things that would possibly be harmful to you. When you have to take it first thing in the morning, that's trying to prevent withdrawal from occurring. So there's no doubt that this person is dependent on that medication.
But addicted is another question.
We don't know. The only way you'll know is as you work to try to slower that And again, you could stop it cold turkey, but
it won't kill you, but you'll be uncomfortable.
You'll feel like you're going to die, but in 8 days, 10 days, it'll be done. Now,
what I would suggest is a 2 or 3 or 5 or 6 month taper, just gradual, little at a time.
We didn't talk about this during the air, but there are treatment facilities in our area that you can go to where you actually go inpatient, and they work with you, and they will actually give you medications to make the withdrawal less uncomfortable.
Yeah.
And those are very, very helpful, because if a person does have addiction, it's not just stopping the medicine. There's a whole mindset that you do, the 12 steps, AA. That's all very, very healthy stuff that you have with that. And so it's not just the pills. There's a disease that goes around it, a mindset. So I really recommend.
And once again, you know, Teen Challenge of Dakotas in Brookings is a source for men who have really been in trouble. And it's a religion. It's a Christian-based method, and I think that is part of its effectiveness. Giving up responsibility.
See a licensed counselor for that, and get into. There are resources available.
Right.
You don't have to do it alone at home.
I have vascular necrosis in my hip, and my doctor's prescribed hydrocodone. I've been taking it for 3 years. 30 pills will last 2.5 months for me. How big of a risk is this for becoming addicted?
Low risk for becoming addicted, and unless he's taking 6 or 7 pills at one time, low risk for overdose. He's probably taking 1 pill. I'd have no problem. I would prescribe it. I would get a contract with him, probably, just saying, are you aware of the potential side effects? Don't drink alcohol with it at the same time. Keep taking the hydrocodone, it's working. If he was addicted to it, he would have started escalating.
He would accelerate it.
Yep. He doesn't have the genetic predisposition.
I had a gentleman who had the worst vascular necrosis. He had been in a car accident, and his knee was straightened and held in a knee stabilizer by the way it had frozen.
Yep.
In other words, he didn't need a knee stabilizer. He was one, but his hip necrosed, and it just hurt and hurt and hurt. Finally, we got someone who would take him to surgery, and he was a new man.
Yeah, that's a situation. If you have something that you can fix,
boy,
fix it.
Fix it.
Yeah, that's the exception, not the rule.
Yes, it is, unfortunately. All right, Dr. Uthe, the last question. That sounds like a Johnny Carson thing. And I have here in my hand. We have a close family member that we suspect could be addicted for quite some time, but we're unsure how to address that issue and get them help without proof. Also afraid that they will deny it and exclude us from their life. Oh, that's a complicated. What do you do?
You do the right thing, and in love, we call it tough love, I would approach the person and say, we are concerned about you. We're concerned about you, that we're going to do something that's very difficult for us, because we know you may remove us from your life, and that's very painful for us, but we care more about your livelihood, and we're afraid that you have a problem with meds, and we feel obligated to reach out to you and give you help. We hope that you'd be willing to do that.
So now, and an intervention, then you believe in intervention?
I do, yeah. My philosophy is I invite, I encourage, I challenge, and I try not to tell. Yeah. Because I can't tell a 2-year-old to be potty trained. I can encourage them and challenge them all I want. I can't tell them. It's the same way the patient who has an addiction. I can't tell them. However, if they're a harm to themselves,
if they're at risk of dying from
that's the one place I say, you know what, this has to happen. You're walking down a path that's to self-destruction. You may die from it. You don't have options.
I would say, by the nature of this question, you can count on it. That person has an addiction problem.
Yep.
And they know it, and they're going to be angry as a hell.
Yep.
But if they know that you do it with care, they won't reject you. If they reject you, they have a mental problem.
Yep. Get a hold of a counselor who's licensed in addictions and in substance use disorders and treatment centers, and get advice from them before you confront them. Right. But I would definitely, tell that patient, tell that family member, this is very difficult for us to do. Yeah. But you got to do it.
Good. Thank you for joining us so much.
My pleasure.
Thank you.
Thanks.
And thank you for joining us on our website. We appreciate all your questions and the opportunity to answer them. So until next time, from all of us at On Call with the Prairie Doc, stay healthy out there, people.